Very glad to have this opportunity. Give a speech focused on a little bit more about advanced heart failure. I'm from the Heart Failure Center in Sichuan Provincial People's Hospital Heart Failure Center. So actually, we are talking about a lot of issues focused on heart failure treatment. But when we come to talk about advanced heart failure, first we need to think what is the definition of advanced heart failure. Talking about this issue, actually we have different names like advanced heart failure, refractory heart failure, or end-stage heart failure. So actually, first of all, we need to think if the patient already have the symptom of heart failure, does this patient already receive standard GDMT therapy? But if the patient already received the very standard GDMT therapy, but the patient still have decompensated heart failure symptom, be hospitalized, we will realize actually the patient already developed into very end stage, means stage D. And also we have another classification which is very familiar with everybody here, is New York Heart Association classification. If the patient have class 3 or 4, we will think that the patient is very end stage of heart failure. But worth to mention is that this classification criteria is actually a lot of subjective, so it cannot be only reliable the symptom complaint of the patient. For example, maybe a patient have very damaged cardiac function, but some of the patient may be lack of symptom. So we need to find more object the criteria or symptom to emphasize actually the patient will realize or pay more attention about the stage. First of all, we need to talk about the hospitalization. This would be considered or regarded as a very strong predictor of all-cause deaths. From the slides, we can see if the patient be admitted 3 or 4 times a year, this be indicated that the patient has also been decompensated of heart failure, arise more pension. This patient already developed into very advanced heart failure. And another thing is if the patient come to the hospital with hemodynamic stable, but the patient still need a continual or intermediate inotropes, or we need to increase a higher dosage of the diuretics to keep the volume balanced. This is also mean the patient is have the inotropes dependent, which means the patient still have a very end stage of cardiac function. Right now, we have other device to very sensitively screen the end stage heart failure. For example, we can do the SIP pipe to make sure the patient still have damaged the cardiac function and the pulmonary function. If the peak VO2 is less than 14, that means the patient should be considered the candidacy of heart transplant and VAD support. Based on the New York Heart Association classification, right now we still have Intermax profile, which show in this slide. We divided into different levels, which from level 1 to level 7. And we can see actually this is quite relevant to classification 1, stage 1 to stage 4, but specifically focused on patient is still have the hemodynamic stable if the symptom even in a sedate, or if the patient already have the mechanic circulation support, this will be arise a more attention to get more advanced treatment strategy. Well, when the patient actually developed into the stage D, the option for this patient is limited. We can still put the patient on inotropes, but if the patient has appropriate or candidate go for heart transplant, we can do heart transplant. But we know actually right now all over the world we still need the daughter heart. So VAD support, which means mechanic circulation support, would be an alternative for this advanced heart failure patient. But here come the questions. When we will consider the patient to implant VAD, if like the patient in the early stage, he is still work. He can still on medicine, he can work, he can doing exercises. This is not appropriate candidate to VAD support. But when the patient actually develops into a kidney dysfunction or liver dysfunction or hypotension, cannot tolerate GDMT, we would consider the patient would be thinking about we can provide the patient have more options of better quality of life. But when the patient develops in very sick stage in his ventilation, transferred to ICU, put on the IBP or ECMO, I don't think this patient would be helpful, or I think at least very difficult to do the VAD implantation. So here comes the window. What is kind of the end of the window is golden window, which means if the window is open, that would be the patient benefit from the VAD implantation or support. But if it's too early to aid, we don't think the patient is the very best or perfect candidate. So from this table, we can see actually we can screen the patient from these different issues. Each character sample size, one character for screening the end stage or advanced heart failure patient. But this is not a criteria to see we can do the implantation was to screen the patient or refer to the advanced heart failure center to evaluate if the patient is still appropriate to do the implantation. Of course, the implantation, we need to the cardio surgeon to do the surgery. And if the patient open the chest and put the inserted device in the apex, and so the patient need a relatively hard time after the surgery and only be rehabilitated in the ICU. So we still need a teamwork. As Dr. Alhaven talking about. In our heart failure center, we do a lot of end-stage heart failure cases. The patient with very sick and staying in the ICU, we put the patient on VAD and the patient recovered and back to the family, back to the social work. So I can say actually if we choose the right person, right time, put the right device of VAD, make miracle happen. But in the maybe 10 years ago, we only have the device that been made in another country. Right now, we have China original Innovateive VAD, and we can see actually this VAD is fully magnifical navigation design, which optimized the follow path and generally had the blood complements, and also have minimized turbulence and maximized washout here. So from the data in China, not in a single center, we have multiple centers. But right now, I just pick a lot of part of the data show actually the support rate is much better compared to the Intermax data. And even the patient being supported by the VAD, and finally he bridged to transplant or bridge to recover and extract the device, we can see that here cannula we cannot find any thrombosis. This to demonstrate that made in China devices also have very superior the lateral to decrease the side effect, which is very I think it's going to be influence the outcome. So the readmission rate here in our cohort in China use the Sage VAD is much better than the Intermax data which used in other country. And also we have another brand of a cohort which also the magnificent navigation VAD also have a very good outcome. Show this slide, we can see that 6 months survival rate is higher than 90%, which shadow a great line for the advanced heart failure in China can also get the support. So finally, I think that for advanced heart failure patient, we need to recognize them, we screen them, we find the right time and the right device and the right patient, so we can change the outcome and get a better quantity for this kind of cohort of the advanced heart failure patient. Thank you for your attention.